aspiration and sclerotherapy for aneurysmal bone cyst, and the second video discussion will be on percutaneous stenotomy in idiopathic clubfoot. So I have made a video technique video. So starting off with aneurysmal bone cyst. Aneurysmal bone cyst is a benign, non-teoplastic reactive bone lesion that is locally destructive. It occurs mostly in an immature skeleton, and it is ubiquitous in the sense that it occurs in metaphyseal region of most of the bones, long bones, bones of the hands and feet, and also in the axial skeleton. The X-ray shows typical eccentric lytic and expansor lesion, and advanced imaging shows fluid levels inside the cavity, and the histopathology shows blood-filled cavernous spaces, giant cells and spindle cells, and strands of woven bone. There might be some indication of a vascular lesion taking place somewhere inside. The exact pathophysiology of aneurysmal bone cyst is not known, but it is said that some kind of vascular malformation, arteriovenous malformation, or obstruction of the venous outflow, leading to increased pressure, coupled with the hemorrhage-induced osteoclastic activation, is behind all the phenomenon. And this is the rationale of using vascular sclerosants in the treatment of aneurysmal bone cysts. So going ahead with the case, this is the X-ray of a 3-year-old child whose X-ray was done incidentally after a trivial fall, and it reveals a big aneurysmal bone cyst. Now, the options would be endoscopic curettage and bone grafting, and open curettage and bone grafting along with implants, or excision of the lesion in toto along with bone grafts and implants. And another attractive option would be polidocanol injection, which is available in India as 3% solution. Now, sclerotherapy is a minimally invasive procedure, and which can bypass the morbidity of the conventional open procedures. In order to perform a sclerotherapy, first we need to find out the volume of the cyst. Though CT scan and ultrasound can accurately calculate the volume, even in plain radiographs, if we take the measurement of maximum diameters, that is length, breadth, and height, and get a product of it, which is actually the formula for volume of a rectangle, but it has been shown to do well with small cysts if we add the magnification factor of 10% in plain radiographs. Now, we are going to replace each cubic centimeter of the cyst space with 1 cc of 3% polidocanol. Maximum allowable volume is 10 ml, but there is a technique to get around this in cases of larger cyst, and that will be discussed later on. Depending on the location and thickness of the cortical wall, we can use either a Jamshidi needle, or we can use bone marrow aspiration needle, or a simple wide bore IV needle. It is better to have a luer lock syringe having a screw luer lock for a good fixation. This is the actual procedure in action. The insertion of the needle may require a small stab incision. The needle may be used to scrape the cyst wall while taking care not to widen the hole of the insertion. This scraping can accomplish what many call curopsy, that is, biopsy with an intent to cure. This aspirated fluid can be sent for histopathological examination. This is how it looks like under the fluoroscopy guidance. Once the sclerogen is injected, it is injected at the rate slow enough to prevent spillover, and which is usually over a few minutes. Once the aspiration is completed, the syringe is kept in situ for about a few more minutes in order to prevent the backflow of the fluid into the open wound. It is also a good idea to use 2 needles, one for the aspiration and another for the injection, which leads to an effective displacement of the cyst fluid and is replaced by the sclerogent fluid. Sometimes dyes can also be used for better delineation of the cavity. Here is how the sclerotherapy works. The fluid inside the cavity is replaced by the sclerosant, which is either polidocanol or doxycycline. Now, especially doxycycline destroys the osteoclast, leading to a net gain in osteogenesis. The sclerosant molecule also destroys the endothelium of the connected vessels, and it leads to their shrinkage. And that's how the cyst ceases to be active. Now, each time injections are given, the same phenomenon happens. The radiographic improvement is assessed at the end of 3 months, and repeat injections are given if required. Generally, on an average, 2 to 3 injections suffice, but up to 5 or 6 injections can be given without any known adverse effects. As the cysts get smaller, it is important to be able to reach to all the loculi in order to make it disappear completely. The end result is restoration of the architecture of the bone and remodeling of the bone to a normal shape in the long run. Now let's see what happens to the case 3-year-old child. So this is the follow-up radiograph, 2 injections, 3 months apart and 15 months down the line. We can see good bone formation and along with the preservation of growth potential of the physis. Now we were talking about tiding over the problems of backflow, spillover, and limitation of maximum dose of injection, which is 10 ml. Turning the liquid into foam has been described originally by Tessari, wherein a smaller dose of drug acquires greater volume if it is turned into a foam. For this, we needed 3-way cannula. We take 1 cc of polydecanol in the lower lock syringe, and we attach it to the perpendicular arm of the 3-way cannula. On the second arm, we take 5 cc syringe and we fill it up with 4 cc of oxygen mixed with carbon dioxide, and we lock it. We don't use atmospheric air as it contains nitrogen, and there is a theoretical risk of having an air embolus going over through a possible left to right shunt if the patient has and causing an embolus. So we fill it up with 4 cc of oxygen mixed with carbon dioxide, and the opening is closed. Now we open the clock slightly, just enough to cause a turbulence, and then the repeated to and fro motion of the pistons about 8 to 20 times will create a fine froth like this. It maintains its frothy consistency for a few minutes, and it has to be injected immediately into the lesion. If we take too small and too thin bore a needle, then the froth will be reconverted into liquid. So we should keep it in mind that we use only wide bore needles in order to do that. So a sclerotherapy is not for every lesion. It should not be performed in pathological fractures, in fractures lesions which are on the verge of having a fracture or are mechanically unstable, if there is any known hypersensitivity, and if the biopsy has been performed, the sealing off of the biopsy site should be allowed, and it takes about 3 months. And it also should not be performed if the aneurysmal bolus is secondary, such as in this case secondary to the giant cell tumor. So these are my video credits. Some of the videos have been taken from the YouTube. Thank you.
Excellent. Sukalyan, can you quickly go to your next talk?
Okay, so I'll begin. Now my second video talk is on percutaneous sternotomy in clubfoot. So Ponseti method essentially consists of 3 stages. One is serial manipulation and plaster of Paris, which corrects the cavus, adduction, and varus deformities. The second important step is the correction of equinus deformity. Before proceeding to the third stage, which is namely the maintaining the correction with the help of foot abduction braces. Now, why a percutaneous sternotomy? Because equinus is not corrected with the help of plasters. As we are talking about the strongest tendon of the human body, if we try to exert brute force, then the weakest link in the chain, namely the tarsal joint, the capsules, and the ligaments give way. They succumb, giving rise to complicated rocker bottom foot. The only way is a complete transection of the tendon, and we have indeed come a long way from the traditional multiple hemi cuts of the tendon Achilles, because we know how the tendon completely regenerates in a matter of just 3 weeks. So percutaneous tenotomy includes 3 stages. One is the injection of local anesthetic. The second is the percutaneous transection of the tendon. And third is correction of equinus to 15 degrees of dorsiflexion, and followed by application of plaster. Now, when to go ahead with a tenotomy? The Pirani score is so versatile that it tells us exactly the time point to perform a percutaneous tenotomy. When the midfoot score is less than 1, and when the hindfoot score is more than 1. In other words, it means when the cavus, varus, and adductions are corrected with the help of serial plasters and the total score comes to a halt. Then the tenotomy is performed to bring the posterior hindfoot score down, which brings the total score down, and that's how the correction is achieved. Let us, for a while, visit the Pirani score. This is the lateral head of the talus, LHT scoring, and it should be completely 0 before we contemplate the percutaneous tenotomy. This is the curved lateral border, and this should also be 0. This is the medial crease sign, and its score should be either 0.5 or 0. Why not midfoot score is 0? Because the medial crease may take a longer time to disappear, and it is a completely benign thing, and it should not hold us back from performing a tenotomy. Another prerequisite is to achieve a complete reduction of the head of the talus inside the talonauricular joint, without which the tenotomy would be too premature. The third requisite is the heel must be in valgus. The fourth prerequisite is to achieve 50 degrees of abduction in an infant. In older children, it may be less. Now that we know when to perform a tenotomy, where to perform a tenotomy. So the guidelines say that it should be in any place where quote unquote a clean environment can be ensured. It can be a full-fledged operation room, or it can be a place where minor procedures are done. A very important step is always to take written uninformed consent. Now, how to perform a tenotomy? This is the inventory that is required in order to perform tenotomy. An important tip is to take a round scalpel holder to ease the twisting of the scalpel to 90 degrees while performing a tenotomy. As for local anesthesia, 2% plain lignocaine without adrenaline, and only a small amount would be required, not more than 0.5 ml. Because we don't want to obscure the feel of the tendon with too much of the subcutaneous wheal produced by the local anesthetic. Now, tenotomy is essentially performed in extension. It is in contradistinction with the from the application of plaster of Paris. The knee is fully extended, and there is a upward push to the foot to stretch the calf. We prep and drape the limb, and then palpate the anterior border of the tendon. We make a thumbnail indentation just anterior to it, and then place the needle about 1 centimeter proximal to the insertion of the tendon Achilles, and inject a very small amount of local anesthetic. After a waiting period of about 2 minutes, we insert the blade pointing vertically proximally at about the same side of the injection. The blade should easily go in, and once inside, we turn the blade posteriorly by 90 degrees. With a genuine gentle motion, coupled with the index finger of the opposite hand palpating the cutting edge of the blade. This proprioceptive feedback is very important, as it halts the further advancement of the blade after cutting the tendon. And because of the protective reflex, it prevents the inadvertent cutting of the posterior skin. Now, a complete tenotomy exhibits 3 signs: an audible snap, a palpable gap, and a visible gain in the dorsiflexion. All 3, as you can see. We apply pressure on the area and wait for 5 minutes until the coagulation cascade takes over. These 5 minutes are important and they are rewarding because we don't want soakage that may seep through the plaster and spoil the mood of both the surgeon and the parents if we apply the plaster immediately. We apply an orthopedic cotton wool, taking care not to dislodge the dressing, and we apply a very snug fit plaster at first below the knee and then going up to the groin. We can fast forward it. Okay, so this is how we are applying the plaster. The final position of the foot should be 15 degrees of dorsiflexion and 70 degrees of abduction. The risks of the procedure, though minimal, should be kept in mind. If we venture too anteriorly and laterally, there is a risk of damaging the sural nerve. And if we do the tenotomy very close to the heel crease, then there is a chance of iatrogenically injuring the calcaneal apophysis, because the calcaneum is high riding secondary to the equinus deformity. So it should be at least 1 to 1.5 centimeters proximal to the incision. After care, we can discharge the patient after a few hours of observation, which is very reassuring to the parents. Analgesics are usually not required. Paracetamol 10 to 15 mg per kg per dose, as and when required basis. No antibiotics are to be given or required. Usual plaster precautions, of which the parents are already aware of because they have already undergone many series of plasters, and we give them advice to come after 3 weeks. My special video credit goes to Cure Internationally India Trust, the organization which has been persistent in training doctors all over India in Ponsity technique. Thank you so much.